I mentioned earlier we were going to have a discussion. It's a continuation of some earlier discussions we've had about elder care and some of those issues related to that. It's called Better Health with Trip Family Medicine. We're at 37 right now, coming up on 834. And I do want to thank you for joining us. If you have a question or comment for one of the medical professionals, we'll just point out right now. Telephone number is 736 0300. 736 0300. Two things that strike my mind right off the top of this discussion is we have a lot of folks who tune in every day who are either in need of some of the care we're talking about, or number two, just about everybody knows somebody who is generally in the family, but if even in the neighborhood. Russell Singleton joining us, a physician assistant from Trip Family Medicine. Welcome back. And you brought a guest this week to sort of expand on this topic.
Yeah, absolutely. I want to welcome my friend Dusty Botraveck here. He's a registered nurse, works for a home health agency, and he and I had a discussion after our last show about how important this topic was, not only caregiver burnout, but in his field, home health, how often he sees that, things that he can do to prevent that. So I wanted to bring him in, have him talk a little bit about what he does. Why is home health, for example, an excellent solution to preventing some of these issues? And maybe we'll talk a little bit about hospice. So I'm really glad he's with me. Thanks for being here,
Absolutely. Thank
Dusty.
you. Yeah, thank you.
Dusty, with a name like Votrevec, are you from Pennsylvania originally?
Not Pennsylvania. No way. Nope.
See that I have a friend who he comes from that area near Scranton and Wilkes-Barre,
Uh,
and he would call you what he calls himself. He calls himself a hunky. I don't know if that's meant to be disparaging or not, but he actually is proud of it, and it tells you a little bit about your ancestry.
right, right. Well, in my ancestry, it's actually like Czechoslovakian, but they would call them like bullhunks. But,
Oh, okay,
anyways,
that's his as
that,
well.
that's a whole nother avenue we'll go down. But, anyways,
Well, I want to thank you both for being here, and we're going to open this up by just talking a little bit about the needs people have. I suspect.
Yeah, so I want to ask Dusty a couple of questions, and Bill, I hope you'll jump in here too if you feel. But home health is a topic that I don't think a lot of people understand. If you ask someone to define home health, I don't know that they'd be able to give you anything. Or on the other hand, they might talk about, well, someone comes in to help clean the house or do the dishes or help grandma take her medicine or something. And it is much, much more than that. So let me ask Dusty, how would you define home health? If you're talking to
absolutely. You
someone,
bet.
they have no idea what you do for a living, for
Right.
example, what do you tell
Absolutely.
them?
So this is kind of a confusing topic. So you've got caregiver, and then you've got home health. And on the home health side, those are licensed professionals that go into the home, and that's what I do. There's a couple criteria that have to be met in order to be qualified for home health. One of those is we have to have a skilled need in order for them to go on home health, and they have to be homebound. So, segueing back to that skilled need would be things like teaching and training on medications, new or changed issues, medical comorbidities, wound care, diabetes, hypertension. Those licensed professionals. You've got a skilled nurse, which is a registered nurse, LPN, physical and occupational therapy. Those are the things that we work on. So back to a caregiver, that's a paid service. So you've got a caregiver, that's a private duty paid service. That's not covered by Medicare. Back to what I do, home health, that is covered by Medicare as long as you meet that criteria.
That's great. Thank you.
Is there a big difference between the two, though, of what's actually done?
Well, I mean, a caregiver basically that's like a CNA
Could be
or
anyone, really.
yeah, it could be yeah, just a friend or whatever. That's like a private duty. So, and that's not covered by Medicare. Versus what we do, it's licensed professionals that go into the home. So, big difference, really.
And I can actually relate to that. When I was in college, working to go to PA school, I was a not a CNA, but just an NA. I was a nurse's assistant. So I
Assistant,
worked for a home
right?
health company, and my job was not medical. I had no training. So I did do things like light housework and help prepare meals. And I think the only quasi medical thing I had to do was wrap this lady's legs with an ace bandage to make sure that they didn't swell too much at night. But it was a very simple task. Now, there was a time when she became ill that we had to have registered nurses come in and provide IV antibiotic, and there's absolutely a big difference. But these folks are professionals. There's a very specific need that they fill.
I was going to say though, even though you're doing something much more beyond than just a caregiver's tasks,
Right.
sometimes there's a little bit of a gray area where you end up doing some of those things for somebody. You get to know them on a friendly basis, and
Right.
you become a little bit of both.
But the government's pretty specific on Medicare on what our role is. Where yeah, we help out with things, but we don't do dishes, we don't do windows, and obviously throughout the community, there's some education that needs to take place. But like for instance, the other day I got a referral from the doctor. They sent us an order for home health, um, all of which you always have to have a doctor's order in order to start home health. Um, so I call up this family. I said, "Hey, it's Dusty with Home Health. I'm going to come out and take a listen to you and see what we got going on." And she said, "Well," it was the daughter that answered. She said, "Well, my mom's actually doing pretty good. She just kind of needs some help with dishes and housekeeping stuff." And that's when we got to do the timeout
Well,
thing.
hold that thought.
All
Yeah,
right, all
yeah.
right.
Got to make it clear. There's a division of labor here. About 20 minutes from 9 o'clock. Short break. We've got more on the way. It's 39. We're talking healthcare this morning, and we're talking about healthcare you may receive in the home, elder care. Although the question I think some people might have too is it's not always related to your age. We have a couple of guests with us, and wanted to point out. Well, we're used to seeing one of them. The other one is visiting us for the first time, Dusty Botraveck, and of course he's talking with us about what he provides and what happens when you need someone to help you with some nursing care in the home. And Russell Singleton is with us much more frequently, and he's a physician assistant at Trip Valley Medicine in Twin Falls, which we should point out is located on Fillmore Street, north side of the city, directly across from the main post office. I used a picture of the office on the web the other day. I was at the post office yesterday too, as well. Um, for those people who are looking for a provider, you're still looking for patients.
We are, and I think I would answer that by saying we are growing with the need. And as long as there's a need, as long as people want a different provider, a new provider, someone who's independent, we're going to keep growing. And I think that is one of the great things that we can do here in Twin Falls is we can grow to meet the need. We're completely flexible.
Now, I wanted to point out too, you're available on Facebook. There's a website, and people can call the office after the show too if they've got a comment or question.
Yeah, absolutely. 933-4400. We'd love to hear from listeners. People again looking to find a new family doctor. One doctor for the whole family is what we like to say. 933-4400. Give us a call. We look forward to hearing from you.
I was thinking about the fact that we're dealing with a lot of older folks who need this care. But I had a friend in about 2007 or 2008. He was only in his early 40s. He had a very debilitating stroke at the time. This can also, there are people who have needs, I think sometimes even, and who was it? There was a famous Hollywood actress, Rita Hayworth, who ended up becoming an early dementia patient when she was only in her late 20s or early 30s. So sometimes there's clearly a need at various ages for this type of care.
Yeah, that's a great point, Bill. So, Dusty, who do you think, or not who, what age was the youngest patient you've ever taken care of? Do you think you could answer that question?
Oh, I think it was a 26-year-old female patient, but yeah, primarily most of our patients are, elderly. They're the Medicare patient in that age frame.
And correct me if I'm wrong here, but the quintessential home health patient in my mind is someone who was just hospitalized.
Right,
So
absolutely.
so they've been quite ill, they've needed 24-hour care. They've gotten a little bit better to the point where they can go home, but they're not ready to be
Right,
on
right.
their own.
They've had a change in condition. Absolutely.
Yeah, so are there any other patients or types of patients that you would say are just perfect for home health? Or if you want to talk further about that hospitalized patient who's transitioning
Absolutely.
back
Right.
home.
So, yeah, I mean, there's a change in condition. You've got them they just coming out of the hospital. When you have patients all the time, so like a total knee, total hip, it's a perfect patient because, they're going to rehab in their own home, the comfort of their own home, and patients do best there anyways. So you've got the nurse that can come in and supervise the wound, make sure it's going well, the medications are in order. You've got a physical therapist that can come right into the home and work on them and rehab, occupational therapist. We've got a medical social worker if we need be, but those would be the ideal patients in that situation.
And I might add too, I think one confusion I had, even as I entered medicine, was that home health is again transitional. It's not meant to be a lifelong service. It's not meant to replace a nursing home. It's not meant to replace an assisted living. We've already kind of defined how it's not meant to be a housekeeping service.
Right.
So how would you approach someone who really needs indefinite care, whether they're 26 or 86?
That's an excellent question. So, I mean, I would probably start that patient out, of course, on home health and give them our best and see what we could do with them. Um, and if things aren't going well, say they're deteriorating, and that's when we could maybe talk about hospice here in a little bit. But, if the caregiver's exhausted, we can't take care of them at home anymore, then yeah, maybe we might look at a facility in that type of situation.
Is there a time limit though when somebody comes out of a
Excellent question. Yeah.
right?
So most of home health have got episodes, and that's how Medicare looks at it. And most episodes are 60 days. And then at that time, the expectation for Medicare is to get in there, take care of that patient, get your goals met, and then you discharge them from home health. But if something comes up in the meantime during that episode and you get to the end of it, at like day 60, you can do a recertification and do another 60 days and try to get those goals met. So the idea is to get in there, take care of them, do what you got to do, and then get them discharged.
And you've mentioned Medicare a lot, and again, probably because the majority of the patients are of Medicare
Right.
age. What is the coverage for home health among private insurers? How often
It-
do you
it-
run into that? How often do you run into, I don't know, like a Blue Cross, Blue Shield,
right.
whatever
That's a
type
good
plan
question.
that
Yeah.
says, no, we're not paying a dime for that?
Nope, no, we haven't had too much trouble with those private paid insurances, and we do take that as well. But I'd say the majority of our patients are Medicare, but we do, private paid or like the private insurance, I should say. Yeah.
A lot of people who I think tune in every week. We talked about this last week. They have a curiosity about just employment in the medical fields, and we talked about how diverse it's gotten last week. For people who would like to do what you do, is there specialized training?
Ooh, that's a good question. And I was just watching some YouTube stuff on this, but um, home health is not for a nurse that's a new nurse. You really do need the skills, of like from an acute care setting, at least a year's training, like throughout the hospital. It's a big job. It's a big responsibility. In a lot of ways, you're like the number one advocate for that patient. You're a case manager. Um, you have to be real flexible and really communicate to that doctor. In a lot of situations, you might be the only person that patient sees. They might be home alone. They have nobody else. And it's your job and responsibility to call that doctor and say, hey, look, we need to change this or can we do this? And that's where Russ comes in and they're a great team and communicating for the best of that patient.
I can really echo that. I've had patients who I see in the office, and I think, what are you going to do when you leave here? Like, I have no idea how this is going to go. What is going to happen when you get into your own house? And I can't tell you how much I rely and trust Dusty and people like him to be my eyes and ears. If Dusty calls and says, "Hey, this wound is not looking good," or I was listening to the lungs and I hear some crackling in there, I take that very seriously because I need him to do things that I can't do because I'm not there. The patient can't come to me. And these are individuals with a lot of experience. Home health is a is a broad, difficult position.
I had a friend who just got discharged from a large hospital run by a university a couple of weeks ago because he'd had problems with an arrhythmia. And I know he went home and he's basically alone at home with the dogs. Uh, uh, there's nobody around. Is there a way if someone's in that situation? How do they go about? Who do they talk to? How do they apply? I guess is a good way to put that.
Right. I think the best way to start would be to get a hold of your doctor. Have the doctor get a hold of us or send us a referral, and then we can set up an appointment with the patient and go out, assess the home for safety, You talked about they had a pet. That's a fall risk right there. So it's just those little things that we're watching for, and all of the licensed people that walk in that home, occupational therapy, physical therapy, the nurse, we're really looking at that home. We're checking every little inch of it for safety. Our job is to prevent a hospitalization.
And I can add too, as the office-based provider, I don't even know all of the criteria. I feel like it changes enough or that it's specific enough to where I just don't keep up with it. But what I know I can do is I can call Dusty, for example, and say, Dusty, I have this patient. I'm concerned about him because of X, Y, and Z. Can you go out and do an assessment?
Right.
And sometimes he'll go out and say, yeah, this patient would be a great patient for home health. We can help them. But I think sometimes you're going to go out, like that phone call you fielded, and you'll say, yeah, you know what, this patient really doesn't qualify. They're pretty mobile. They're pretty independent, or they don't need anything from
Medical. Yeah,
medical from
medical.
a
Yeah.
skilled provider. And then I'll say, okay, well, thank you for looking. Because then I feel better, family feels better. We've looked into it.
Two things that immediately came into my mind as Russell was talking about that. There's got to be a lot of paperwork involved,
Oh,
and
it's the government.
number two, you have to be a diplomat, I would think, as well.
Yeah, the government. And I think that's where some of the confusion might be coming in as far as the community. What is home health versus a caregiver? It's because they've changed it. It's the government. They change stuff all the time. We have new regulations every single year. So, yeah, it is difficult. And there's a ton of charting and documentation, but that's part of the job.
Yeah, I see that on my end, and it has both good and bad effects. Number one, everything Dusty does is documented. So I get a report after probably, if not every visit, every, I don't know, every 2 weeks or 3 weeks saying, we did this, we did that, we did this. These were his vitals. I changed his dressing, or I did whatever. And it's all written down. It's documented very, very well. It's part of the medical record. And then he'll send that to me. Sometimes it's just for my information. Sometimes I need to sign it and send it back. So so on the plus side, this is a medical service documented and provided professionally. And then on the bad side, there's a lot of hoops that you have to jump through to make sure things get paid for and to make sure if you're ever audited that all your T's are crossed and I's are dotted. But
The patient, to some degree, if they can cooperate, is probably good. When my dad was in his later years, he would have a nurse come by, and he had a list of prescriptions that he would take and the times he had to take them, and he would document that for her, so she knew what he took in the morning, she knew what he took in the evening, and it made her life a lot easier. But you're going to be dealing with some people out there who probably can't even recall if they took the pills the night before or even in the morning.
That's a really good point. And I think in that particular situation, what I absolutely love is a med set because it's got the day of the week, and you can go back. Say I go in there twice a week, because home health is intermittent. We're not there every single day, and I can go back and look and say, yeah, we've taken all of the meds, or you forgot Sunday and Monday, and here's today's Wednesday, so you've forgotten a couple. But the other thing that helps in that situation, is bubble packs. So like R&R Pharmacy over in Jerome, they do bubble packs, and some of the other local pharmacies do that to help that patient try to stay on track. And medications are a huge, huge issue in the home.
yeah,
So
those bubble
everything's
packs are awesome.
Yeah.
everything's separated and put in there together, so you
So they
just
got
take
the
the.
right drug, the right time. Yeah, XYZ, it's all lined out for them.
I can't tell you how many times I've seen patients empty entire bottles out into larger containers.
Yeah.
Or they'll just empty them all out into the counter and like separate them by color or by size, and then they bring them in. They're like, "Well, I'm taking the little yellow one, but I haven't taken the white one very often." And I'm like, "That's 90% of medications. I have no idea what you're talking about."
A friend of mine used to come into Bob Evans, and he would literally pull out a little bag and dump it into a Dixie cup, and then swallow that down with his orange juice in the morning, and that was his part of his day. And he was
Hmm.
a relatively young person still at the time.
So if we have time, and Dusty, if you feel capable of answering this, can you tell us a little bit about hospice care?
Oh,
That's
that's a
something
great
that
question. Yeah,
that your company provides. It's different
it
than
is.
home health. It's a
Absolutely.
lot different. Can you tell us how?
Absolutely. So, like, even with our company, they don't particularly like a home health nurse to do both hospice and home health just because the documentation is so incredibly different. It can happen, but they prefer not to. But anyway, so typically we'd start a patient out on home health and try to get them stronger, better, do their thing. And if not, like I was saying before, they start to deteriorate or go downhill. That's when we can start talking to the doctor. What do you think about hospice with this patient? They're kind of going downhill. Um, and if the doctor's okay with it, then we would consult with our hospice team and they'll go out and do an evaluation and say, do they meet the criteria now for hospice? I mean, and just like home health, we've got our criteria they got to meet, and they got to have the hospice that's got to meet their criteria as well. So consultations are excellent.
But can we break it down even further and talk about what hospice is? Because if I bring that up sometimes to a family, they think I'm trying to kill grandma, and and that's not that's not at
Right.
all what it is.
And I think hospice, unfortunately, and my hospice team will kill me right now, but the word hospice sometimes is as bad as the word cancer. I mean,
Yeah,
people
exactly,
hate that
exactly.
word hospice. And you know what? It's not the end of the world. We've even got patients back from
Yeah,
hospice. They
yeah.
got better on hospice, and we get them back over to the home health side. So, hospice is usually more care, meaning we have more nursing visits versus home health.
And if I had to define it, I would define it as improving quality of life versus
Absolutely.
quantity.
Right.
I think home health is about restoring function, getting you back to
Right.
independence, where hospice is a recognition that there's a probable or more likely than not chance that you've got a 6 month or
Less
less
to live. Excellent.
prognosis, or you've got 6 months less to live. And it is all about making the patient comfortable, everything from physical needs to mental and
Right.
emotional,
Emotional.
spiritual
Yeah.
needs. And I am a big believer in hospice. I think we need to get people out sooner. I In hospice, I think the big problem with hospice is sometimes as providers, we wait until like the patient's going to be dead in the next 24 hours, and we call in hospice, and
Right.
we've wasted such a huge opportunity to provide, again, transitional care.
We've got a few seconds to go. Contact information again for both of you in this case.
Yeah, Trip Family Medicine 933-4400.
Yeah, and I got Idaho Home Health. You can get a hold of our office at 934-4842 or the Twin office, 734-4061. And I got to do a quick shout out to a couple people that have really helped me get where I am today, and Alan and Marilee Stevenson. Thank you.
I hope they're tuning in.
Yes.
Yeah, well, we'll have a copy of it anyway afterward.
Excellent.
Want to thank you both for coming by.
Thanks, Bill.
And 9 o'clock news coming up. Quick note: I just got this passed along from the Otter office. There was a mild earthquake in Chalice just a short while ago, 2.7 on the scale. You likely didn't feel it here. If you did, though, now you know it wasn't just somebody looking at you when the earth moved. News is next from Fox at 9 o'clock.